So good morning, everyone. Thank you, John, for a nice introduction, and also good morning to everyone who joined us via Zoom. I'm talking to you this morning about peripartum depression. I will tell you a little bit about the current evidences about the clinical presentation and what are the possible impact of peripartum depression and how to manage this problem. And then we will relate peripartum depression to birth experiences and give some implications for the end. But before we begin, I will show you photos of some balloons. So we have balloons in different colors, in different shapes, with different uses and purposes. We even have them in different animal shapes. And why I'm showing you this, you will have to wait until the end of the lecture to find out. Okay, so what to tell about peripartum depression? So there is a bulk literature on peripartum depression. Okay. If you put it in a Google Scholar, terms like postpartum depression or postnatal depression or peripartum, perinatal, you will get lots of results. And we can see that there is a exponential distribution of papers in recent years, which I think it is if you Google all different terms, because we write so much lately. But I pointed out a year in 87, which I think that it is when Cox and colleagues published a paper about the postnatal depression scale, which is the mostly used in research on postpartum depression. And I think that it really helped in future studies. But we can see that it took some time to increase studies after that. So if we see that there are almost probably 200,000 papers on postpartum depression, I was really overwhelmed with this number. And I was thinking, oh my God, how am I going to talk about the current state of art in this field when I didn't even read less than 1% of these papers. It was a quite overwhelming moment for me, I have to say. But I will tell you about, among others, about some papers that we published within the project that I first started working on, and the recent project that was funded by my university. I just got funds for another project. It will be a 3-year project, so I hope to have some interesting results. And also, I'm a part of Depressed project collaboration that is led by Professor Toms from McGill University. So he and his marvelous team gathered all papers on using EPDS. And they collected the data from our studies. So they have massive data, like 20,000 people from original studies, and doing really extraordinary statistics. But mostly I will talk about the papers that recently came out from Cost Action Rise Up PPD, where also part of, and I'm their leader of working group on prevention and treatment, the largest group with 90 people, and it is really, really active cost action. And also I will use a system findings from systematic reviews, and especially are useful umbrella systematic reviews. Umbrella reviews are those, because there are so many systematic reviews, so we need systematic reviews of a systematic reviews and meta-analysis, and these are called umbrella reviews. And when I wanted to find a photo of or image of umbrella reviews, then Google put me out the results, which umbrellas are the best to buy. So this is Repel. I'm not making a commercial, but this is apparently the best one. Yeah. So to start with the basics, what is peripartum depression? So it is a non-psychotic depressive episode of a mild or major severity with peripartum onset. But there comes the problem. So what is peripartum onset? So we know that in the last version of DSM, it was only postpartum onset, so within 4 weeks after childbirth. But in the DSM-5, it was changed during pregnancy, but still only until 4 weeks after birth. However, recent studies, well, not only recent studies, but we have a lot of studies even from before, saying that a postpartum depression can happen for the first time even during the first postpartum year. So we shouldn't restrict only until first for 4 weeks. So when I'm saying talking further about peripartum depression, then mostly it is from beginning of pregnancy until the first year of postpartum. So the prevalence, the older reference of O'Hara and Swain from 96 was that is from 10 to 13%, but we see that recent papers are showing a higher percentage, and these two references are from also systematic reviews. So this quite stable figure. However, there is a wide range across countries. From 3% to even 38%, and we have a higher percentage in low and middle income countries. And these variations could be attributed to the income inequality and also mortality. So as I said about the onset, so before it was some study also during the whole first postpartum year, but it was evident that most cases really develop in this first few postpartum weeks. However, as we moved and DSM also moved to this whole pregnancy and postpartum period, new studies are showing that actually really a major part of postpartum peripartum depression starts in during pregnancy. So 70 to 80% of women actually start feeling depressive symptoms during pregnancy, which is really important when thinking about implementing prevention and screening, including in treatment. So about the symptoms, the two major symptoms are depressive mood and loss of interest. But what is interesting about peripartum depression in comparison with depression that happens anytime during a lifetime is that anxiety has a really important clinical presentation in peripartum depression. That is something that is not so common when we are talking about depression during lifetime. And there are other symptoms, especially feeling of guilt and shame, feeling as not being a good mother, And there are also other symptoms of depression, but which are somatic symptoms, and that could be easily mistaken for normal pregnancy feelings. And also there are normal changes during pregnancy and postpartum. So women might feel fatigue, especially during the first trimester, and they will definitely have disturbed sleeping after the baby is born. And so there are lots of these changes. So we should put focus on these first symptoms, and that is why Edinburgh Postnatal Depression Scale is good, because it doesn't have these somatic symptoms, because they are not very distinctive. In this paper, the authors are raising issues about specific subtypes. And this is something that is still not very well covered in papers. As we said earlier, that we have quite a lot of number of studies, especially since EPDS was published. I think that we should have known better by now, but still this is something that is not very well studied. In order to give them a tailored interventions and treatment. However, this recent study made these 5 subtypes. They used EPDS scale, and there are like 3 factors. So one is depressed mood, another one is anxiety and feeling overwhelmed by daily stressors, and the third factor is anhedonia, which is related to not being able to feel happiness. They found distinctive types. So there was severe and moderate anxious depression. These women had both depressed mood and anxiety. The severe was more intense. The third type was anxious anhedonia. So they didn't have so much depression symptoms, but anxiety and not being able to feel happiness. And there was about 10% of women with pure anhedonia, so not as many depressed and anxiety symptoms. And also 1/4 of women had resolved depression. So they had depressive symptoms before, but until when they at 8 weeks postpartum, it recovered by itself. However, it means that 75% of women didn't recover by 8 weeks. So it is not something that will go on as by itself. It is interesting to see when these subtypes are starting. So the severe anxious depression will either start very early in the pregnancy, so in the first trimester, or later after 8 weeks of postpartum. And the most severe cases were these with anxious anhedonia, with beginning in the first two months. And pure anhedonia has a very early onset, so we are talking about first for postpartum weeks. Those women that develop depression during late pregnancy have this mild clinical presentation, and those are women who recovered from depression by themselves. So we can see that it's very important to not just to say this woman is depressed or not depressed, she has elevated symptoms of depression, but it is important to look at what kind of symptoms are those and when did it started. And then we can a better tailor the treatment and see what is the intensity of these symptoms. So regarding the risk factors for depression, there are so many studies and so much risk factors that have been established, and we can look at them from biopsychosocial perspective and categorize them a little bit. I cite here two systematic, two umbrella reviews. So the first one reviewed 11 systematic reviews with 185 original studies with more than 3.3 million women. And the second one reviewed 21 systematic reviews. So we can say that these risk factors are really, we can be very sure about them. So from biological category, the two that were most with the strongest effect was premenstrual syndrome, which actually show us that women who are susceptible to hormonal changes before pregnancy might be then susceptible for depression during pregnancy and after childbirth. And the second one is gestational diabetes. And this is something that we have just started working on. So we know from studies that, and Maya will especially work on this. So we know that from not just peripartum, but from general population, that people who have depression, they're more prone to develop diabetes. And we also know that people who have diabetes are more prone to have depression later on. There are also some data that are showing that this association is true for during pregnancy, but they are still lacking longitudinal studies. So that would include women that don't have gestational diabetes and then having the follow-up in the right time. So we are going to have a longitudinal study with 3 time points. So before gestational diabetes is diagnosed and after at the end of the pregnancy and then after childbirth. So we will see this hopefully in this prospective manner. From psychological risk factors, the major ones are prenatal depression and high life stress. And from the social ones, current or past abuse. So this was the first major risk factor. And I don't think that this is paid enough attention. Then lack of social support, marital dissatisfaction, and unintended pregnancy. So as I say, these are from umbrella reviews, so we can be really sure that these are the strongest one and that we should pay special attention for these risk factors. So what are we know the story before it happens. So what happens with women that have postpartum depression and peripartum, and how this affects the whole family. So we know that it affects normally mother's mental health, but also physical, especially in this relation to diabetes. There are also higher rates of suicidality, and we know that perinatal suicidality is the leading cause of maternal mortality. So this is something that is preventable, that we should prevent these kind of deaths. There are also adverse effects on a baby and the relationship between mother and infant. So mothers who are depressed are less sensitive and less responsive to their infant's needs. Mothers who are depressed have a poor bonding with their baby, and it affects infant to parent attachment. However, there should be a distinction here between depression and depressiveness. So depression is when you conduct an interview and you know that a woman has all criteria for depression, and depressiveness is if you only give like EPDS or some other scale and you measure symptoms. So in this review study by our Polish colleagues, they show that depression is the one that leads to all these adverse effects on bonding and attachment, but depressiveness, there is not so a stable, strong relationship. So we should also pay attention to this really like clinical level. And also there is a bulk of literature showing that there is an association between peripartum depression and child development, so psychomotor and cognitive, social, emotional during childhood and teenage age. However, if mother has a more severe depression, then this is greater risk. And it also has an effect on a father. So the relationship with the father may be affected. And what is interesting that father-infant interaction is more affected if mother is depressed, but not so much if the father is depressed. So it seems that mother is here as a glue that connects the family together. And also if mother is depressed, then there is a higher risk that the partner will be also depressed. So we get here one vicious circle that we have to stop. So I will not talk much about peripartum depression in fathers, just briefly, because we want to relate this to the birth experience. So, but we know that prevalence in fathers is 8 to 10%. And what is interesting about the symptoms, so how it will be presented in fathers. So the symptoms are not as clear as in mothers. So the depression in mothers and in fathers are, we can see it differently. And so in fathers, we can also see mood alterations and anxiety as in mothers. However, in fathers, we see more behavioral problems. And this can be seen as more hostility and aggression. And they might also be concerned about the progress of the pregnancy and the infant development. And this can be almost as on obsessive level. So these worries about the infant. However, if you remember from the slide on the risk factors for women, so if we have this is the vicious circle. So if we have depressed women, we will have more depressed fathers. They will be more hostile and aggressive and perhaps more abusive to his partner. And this is, again, additional risk factor for her depression. So we get really this circle. And as I said before, so the main risk factor for peripartum depression in father is maternal depression. So I would like now, after this clinical presentation of peripartum depression, to say a few words about prevention and treatment. Except that we heard about all these adversities by peripartum depression, there are also costs. So not only that family is affected, but also the whole system, so health system, and also educational and on a higher perspective. So Annette Bauer had colleagues had these calculations in UK and calculated that total lifetime costs of peripartum depression is 75,000 pounds per woman. The majority of these costs are actually related to adverse impact of in children, so including the healthcare, but also the impact on educational systems. So they're having problems in school and things like that. So this is quite an amount which put us into the pressure that we have to prevent this. What are studies saying about prevention? Counseling interventions are associated with a lower risk of PPD onset. So in this way, they are effective. And of these different counseling intervention, cognitive behavior therapy or CBT has been proved as effective prevention intervention. And this is interesting to note that it is found that it is more effective. It is when it is applied postpartum rather than during pregnancy, and it is more effective if we approach it individually rather than having some group interventions. Family therapeutic interventions were also found as effective. However, there's one methodological notion from the authors that reviewed different studies, and they pointed out that the most evidence is working for women at risk for PPD. But if we are talking about primary prevention, that we would talk about all women, not just those exposed to risk. So future studies are needed to see how prevention programs are working for all women, so not just those at risk. Before talking about the treatment, we have to know that first women have to seek for the treatment. So they first have to recognize that they have some symptoms, that this is not something that is normal, or that is something that will pass by itself, and that there is a help for this. However, what is pointed out is that peripartum depression is still underdiagnosed and untreated as it should be. We don't have much data about how many women ask for help, but those that are available are really devastating, showing that at least 60% of women are not seeking for treatment for peripartum depression. And why aren't they? Because we have a treatment that is effective, as we will see. So there are many things that can prevent them from asking and seeking help. The first one is a fear of stigma. So they are afraid that they will be categorized as non-adequate mothers by their family and by their close surroundings. So because of feelings of shame, guilt, they will not ask for help, but these are the symptoms of depression. So this is also one circle that I think raising awareness about this can really help about this. It would be like you have you broke your leg, so this is symptom, you have broken leg, but you will not go to the hospital because you have a broken leg. You can't walk there, right? So we have the same situation. And I think that we really need to raise awareness about this. And as many women spoke about this, we might get there to change this a little bit. And also, for some countries, there are, even in well-developed countries, I would say that there are lots of disparities between major cities and smaller rural areas. So as we have treatment, we know what it works, but then it is sometimes difficult to have it available for all women. I will say now a few words about treatment. So first about psychopharmacological treatment. These two studies are about, there are review studies on clinical practice guidelines in Europe, and the first one is from the RISE UP PPD. Actually, they're quite, the clinical practice guidelines are quite inconsistent when it comes to what to do with women who are old cases. So we have women who were depressed before pregnancy. Some say that it should be continued using antidepressants, but without evidence, and some do not say anything. About new cases, if it is mild to moderate, then psychotherapy is the intervention of first choice. And if we have severe depression, then antidepressants are recommended. During the postpartum, recommendations are suggesting monitoring the infant, and they do encourage breastfeeding. Of course, this has to be in a close look by a psychiatrist, of course. But this is something that is also one fear of women, that they should have to quit breastfeeding, so they don't want to ask for help because of this. However, studies also point out that anxiety is overlooked in these recommendations, and we heard before that anxiety is one important aspect of depression. Regarding the psychological treatment, this is a systematic review. This one is also from RISE UP PPD. Show that psychological interventions are effective for PPD treatment, and so they show that it got us to a reduction of peripartum depression symptoms, even when looking short-term and long-term. So this is very important. And from those that were inspected, cognitive behavior therapy again was proved as the most effective treatment. But we heard that for prevention, individual CBT was more effective. However, for treatment in any kind of format, it worked. So either individually, in group, or something that is more popular now, so online, using different applications and so on. And this is also something that we have one group in RISE UP PPD that are working on a non-invasive brain stimulation techniques. So these are non-pharmacological and non-psychological, and they do not require surgical treatment. Of these, for transcranial electric stimulation and electroconvulsive therapy, there was weak evidence about effectiveness. However, for repetitive transcranial magnetic stimulation, there was a show that that it is effective. However, it is safe for application after childbirth. So not during pregnancy. So this is also something to think about, because mainly we think of either drugs or some kind of psychotherapy. But in order to deliver some treatment, you have to have some clinical practice guidelines that would be like on a national level, so that all practitioners working with this population can know what to do, when to do, whom to direct women, and things like that. However, we have quite a bad situation regarding clinical practice guidelines. So this is a study that is currently in review also by Cost Rise Up PPD, and Maya and me are also part of this group. So we tried to find as many recommendations in all European countries. However, we found that only 11 countries have a specific CPGs for peripartum depression. So any clinical practice guidelines that mention anything about what to do with peripartum depression. However, of those that we found, the quality was really, really low. And we can only imagine how this can lead to all the inequalities across Europe and the treatment of depression. In Rise Up PPD, we have now a large it is our main goal until the end of the cost action is to write a clinical practice guidelines that work, that would be evidence-based and covering all these different topics. And I'm co-leading this with a colleague, Mariana, from Portugal, and we have a good team with different backgrounds. So we hope that we will have this ready by the end of the action. Of course, then it would be another challenge to implement this at different countries across the Europe. Okay, so our cost action is about birth, and let's see how peripartum depression is related to the birth experience. So I will not speak a lot about this, because I think that we are here all on the same page, and that we know how much a childbirth is really one complex event. And we can see, we can look at birth experience from a women's perspective, but we should also look at birth experience from perinatal healthcare perspective. And here International Consortium pointed out that the birth experience, we can see it here, is one of the crucial indicators. We now have to ask women what they feel about the birth. Are they satisfied with it? And it is not just the survival of mother and a baby, but we have to run this circle all around, and we have to have this complete experience. When we want to see the association of PPD and birth experience, we can look at it from two sides. So we can see how depression during pregnancy may affect birth experience. So how women who are depressed during pregnancy, what will be their birth experience when they come to maternity ward. And we can see the other side. So what kind of birth experience will lead to postpartum depression? I have to say that there are not so many studies. I had quite struggle with this. There are not so strong evidence that depression during pregnancy will be associated with some outcomes, birth outcomes. So there are quite, I would say, a lack of studies between depression during pregnancy and birth satisfaction. But there are more studies about the birth outcomes. So it might be that depression is associated with a low birth weight. But one study said that there won't be association if smoking is controlled for. So we still might need to look at specific mechanisms so to find out about this association. However, depression, prenatal depression and prenatal anxiety were associated with longer labor, longer administration of epidural analgesia, and oxytocin administration during labor. And these clinical aspects of delivery were then related to, so adverse clinical aspects were related to lower APGAR score. So we can see here that there are some association with birth outcomes. And here is here the childbirth pain is something that really comes up. So we have one Croatian study showing that depression during pregnancy was associated with expected pain. So women who were depressed, they expected that the childbirth will be more painful. However, they follow them from pregnancy and at birth and then later on, and actually depression during pregnancy was not associated with their actual pain during childbirth. However, also these expectations could be, we talked yesterday also about these unmet expectations, but when there are fearful expectations, and especially if women is catastrophizing the pain, it could lead to adverse birth experience. And some studies were looking at cesarean section and pain associated with cesarean section and how it relates to depression. However, it showed that a cesarean section was not associated with PPD. However, acute postpartum stress and so within the 36 hours postpartum, so this pain and stress was related to persistent postpartum pain, so measured 8 weeks after childbirth, and with depressiveness. And what is interesting that this relationship was established even after controlling for current pain. So there was a strong correlation between what women feel and how they experience stress and pain immediately after childbirth with depression later on. But we have something that is called normative maternal pain, and these authors followed women longitudinally, and they found out that in the third trimester pain gets a little bit increased and then decreased in peripartum. So they call it like normative maternal pain. However, in those women that got increase in the third trimester, it was a predictor for postpartum depression. So we can say that there is a normative pain. So all women will experience some painful sensations during pregnancy. But if there is a increase, it will lead to more depressive symptoms later on. And what we well know, and what is done in this cost action especially, is this relationship between traumatic birth and post-traumatic stress disorder. So I won't talk as much about this, but we have to be aware that almost so 1/4 of women experience childbirth as a trauma. However, not all of them will develop PTSD. So the systematic review by Dickman, Yildiz, and Susan showed that Susan Ayers that the prevalence is around 3 to 4%, and some of the contributing factors. So there are many more, but one of the most distinctive ones are perceived loss of control and insufficient, inadequate support during childbirth, and invasive obstetric interventions. So we know that these are contributing to PTSD. So how does this relate to the depression? We will see next. And systematic reviews show that in majority of studies, there is an association between negative birth experience and postpartum depression also. So we have negative birth experience relation to PTSD and negative birth experience in relation to postpartum depression. However, they pointed out that birth experience is measured with all kinds of instruments, and International Consortium recommended to use birth satisfaction scale revised by Caroline and Colin, who we also used this scale in Croatia, and I think it's currently in 40, already translated in at least 40 countries worldwide. So we said that the birth experience is associated with PTSD and with depression. We see from studies that there is a high comorbidity between PTSD and postpartum depression. However, there is a larger comorbidity between PTSD and depression than with depression and PTSD. So what I tried to be figurative. So this means that women, in total, we know that women with PTSD, there are 3 to 4%. So this is a smaller circle. And we have at least 12 to 17% of women with depression. So therefore, we have a larger circle. However, women with PTSD, most of them will have also depression. So only this small part on this left-hand side will have only PTSD without depression symptoms, but majority will have comorbid depression. And we have to be aware that when we are providing a treatment. And if we look at the depression, we know that only 1 in 3 women with depression will also have PTSD. But what is the problem if with the screening? That is, if the screening is implemented in the first place, it will mostly be only for depression, and the treatment would be quite different for women with comorbid PTSD. So when thinking about screening, we should screen not just for depression, but for PTSD and for other anxiety symptoms. So if we are looking at the birth experience and peripartum depression, postpartum depression in this case, then it looks like that PTSD has this mediational role. And from our studies, we found both direct path between birth satisfaction and depression, but also through PTSD symptoms. So women who had more negative experience with the birth, they had more PTSD symptoms and higher depression symptoms. However, also the problems with previous studies was that PTSD symptoms were measured with really outdated questionnaires. So we used a recent questionnaire developed by Susan Ayers and colleagues called City Birth Trauma Scale, which I think you are well aware of. And this scale has two set of symptoms. So one set of PTSD symptoms are those that are birth related. So if women get nightmares about birth, if anything can trigger their memory of birth and such a thing, this would be birth related. And there is another set of symptoms called more general symptoms, but that include negative mood changes, negative cognitions, and which are also one aspect of PTSD. And we saw that birth satisfaction was obviously related to both PTSD set of symptoms. However, we found this indirect effect. So birth satisfaction was associated with only with through general symptoms to depression. And here is when you think about that comorbidity, before it is actually a comorbidity between these general symptoms, so more like dysphoria and depression. And okay. I just wanted to say that then we also looked how depression is associated then with mother-infant bonding, relationship, and Susan and Antje also had these studies and showing these mediational roles between PTSD and depression to these different outcomes. Okay, so what can we conclude anything? So these are some implications. We've seen that there are so many studies. So do we need more studies? Yes, we do. But I would say then it would be start to look at these umbrella reviews and search from there. But I think that we would need more representative samples and with longitudinal designs. So, and looking more into mechanisms, what is behind. As we see that there is a devastating situation with clinical practice guidelines in Europe. So we need really evidence-based CPGs. So to know how to manage peripartum depression. I didn't much talk about the screening, but there are studies showing that it could be cost effective, and we have a Gulkan who is leading a group that that will work intensively on this. However, we should be careful with recommending screening, which is something that you will always read at the bottom of every paper. So we have to screen, and but it is something. If we screen women, but we don't have process in the organized system that we will then have a place where we will then direct women to have a treatment proper, then it might even be non-ethical to do the screening. And it has to be seen if it is really cost effective, because in order to have screening, you have to educate mostly midwives and nurses who are first in touch with women, and then you have to have this whole system around this. So as I said, this is yet to become, so stay tuned. Yeah. And I think that the last thing is that we can never speak too much of these problems, especially in the public. So we have to speak out about these problems, and sometimes even just saying what the symptoms are can be really, really crucial for some women, because they can't see it. Their family, they know that something is not right, but they don't know what it is. Is it something that is normal? Should they ask for help? So we should raise awareness. And there is a World Maternal Mental Health Day on 4th of May. I'm not sure, John, if we are global partners of this campaign. RISA PPD joined last year, and the non-governmental organization that I'm leading here in Croatia, we joined also, and they're really active in speaking about this, and it is very easy to become a global partner. So Antje, maybe we could do this in a dissemination group. And they have really nice infographics and everything online, asking for partners to translate this in as many countries, in many languages, and they posted everything online, so everyone can share and download. And this is just one type of raising awareness, but I think that speaking publicly about these topics is very, very important. And so to conclude, I have to say that this was the most difficult part. So what can we conclude? Because I quite raised a lot of questions. So, and we are still working on so many things. But what we can say is that peripartum depression is prevalent, and we saw that it impacts the whole family and the system because it is costly. But prevention seems to be both feasible and effective, so we should aim to implement prevention and to stop the vicious circle of peripartum depression in families. We also saw that peripartum depression and birth experiences are associated, but I think that we need more studies here to see exact mechanisms. Is it only through birth, through PTSD or others, and what are the biological mechanisms behind this? And Jonathan talked about this during the training school. And finally, we should invest in care for high quality of perinatal health care, where the high birth satisfaction is a must. Yeah. So as Cyril Tatano Beck called postpartum depression as a thief that steals motherhood, we should really be aware of how devastating this is. And again, not just for mothers, but also for the whole family. And so in this moment of darkness, some are more resilient, so they overcome these obstacles by themselves. But for some of them, they need the help, and that's why I showed you balloons from the beginning. So I think that we are those balloons. We come in different shapes, different colors, from all geographical locations, but we can all do and make a difference. So, thank you.